Hi there, it's Sarah here from BJC Health, coming to you from Sydney, Australia. Thanks for showing an interest in one of our educational events. You're about to watch part one, so enjoy the event. If you've got any questions about the content, then please consider joining BJC Connect, where you can access all of our facilitators live. Otherwise, please consider leaving a comment and we'll do our best to get back to you.
Hi everyone, my name's Michelle, as Sarah introduced, and today we're just going to be talking about arthritis of the thumb and fingers, and just some different strategies in terms of just managing it. So as we mentioned, topic that we're going to cover tonight is an understanding of arthritis, the cause, the effect, including some research in regards to that. We're also going to talk about management strategies, whether it's targeted pain relief, invasive, non-invasive treatments, as well as enhanced self-management skills. So whether that is adaptive tools, modifying your daily tasks. And at the end, we're just going to have an Ask Me Anything session. So as we mentioned, you can pretty much ask whatever you like, write them down in the notes, and I'm happy to answer any of them at any time. So just to start with, what is arthritis? So in its most simplest form, it's defined as inflammation of one or more of your joints. Okay, the two most common types of arthritis that people have probably heard about is osteoarthritis and rheumatoid arthritis. So the rheumatoid arthritis is probably more the systemic one. So today I'm probably going to be more focusing on osteoarthritis, though a lot of the treatments and what you will do in terms of management will be basically similar in terms of rheumatoid arthritis as well. Arthritis is a condition, and it's characterized by progressive loss of articular cartilage and remodeling of the underlying bones. So you can see in the picture here, you can see the healthy joint. And what I try to get people to think about is, when you eat a chicken and you break the leg or, the joint, and you can see the white kind of cartilage, and that's that blue line that you can see on the healthy joint. So what you'll find is with osteoarthritis, which, often people kind of talk about wear and tear, basically that cartilage starts to wear down. And so you can see on this second image where basically the bone is kind of rubbing on bone and it's all kind of red and inflamed. And that's essentially what arthritis is. It's the inflammation of the joint. So the process, fairly simple process, as we talked about, normal healthy joints move easily because of the smooth, slippery cartilage. And although we have traditionally talked about it being wear and tear, what they have found is a lot of times is that cartilage actually degrades. It remodels, and there's an active response in the cells. Okay, there are inflammatory cells in the surrounding tissues, and these cells essentially destroy the articular cartilage. And by doing that, there's a reactive process, and that can lead to the formation of osteophytes, bone cysts, and where the joint space becomes progressively smaller over time. So you can see kind of those stages in the pictures there. Risk factors. So there's heaps of different sources of osteoarthritis. And often I kind of say, look, to anyone who's, over the age of probably 20 or 30, if you had an x-ray, you probably have osteoarthritic changes. And just because your x-ray may look terrible, that doesn't necessarily mean you have really bad pain. And conversely, if you have, a perfect x-ray, some people have really bad pain. So often what your x-ray shows isn't necessarily what you're actually feeling, okay? Arthritis can be caused by a number of things. So primary things, it can be primary, so it has no obvious cause, or the arthritis can be caused secondarily. So that's due to trauma or some sort of a disease. So risk factors, obesity. So that's probably more so for, your weight-bearing joints, so your hips, your knees, and your feet. Advancing age, like I said, we can't really stop the aging process. So it does happen to everyone, but to a lesser or more so degree, depending on who it is. There is a bit of a genetic component. Generally, females will have more arthritis than men. People in more manual occupations, and also ethnicity. So I think kind of African background have less likely chances of having arthritis as opposed to other populations. So what we're talking about is with arthritis, it is just general wear and tear. But what I try to explain to people is with arthritis is of often flare-ups of your arthritis. And this can be as a result of a number of things. So whether it's stress, whether it's cold weather, whether it's repetitive motion. So you decide to go out to the garden and spend 3 hours out in the garden using your secateurs, and then your hand hurts afterwards, okay? So that, again, overdoing activities, medication changes, and then also falls, where people have probably had some arthritic changes in their hand. They've fallen, they've kind of created a bit of extra inflammation in their hand, and that almost sets off this kind of flare up or a bit of inflammatory cycle within their hand. Signs and symptoms of a flare up or of osteoarthritis. So there's lots of different ones. So often people will notice that they have crepitus, or that's kind of like crunching or cracking of their joints. They have pain in their joints and stiffness. They will notice that their pain will get worse with activity. All right. Their pain will be relieved by rest. Their joints are generally swollen. Okay. It can get worse throughout the day, the pain, while the stiffness tends to improve over the day. So that's as the joints warm up. So most people will find that their hand will feel most stiff in the morning and it will feel most flexible at the end of the day. As a result of the pain, often people will realize that they have a loss of strength. So with prolonged osteoarthritis, you will get some deformities, as you can see in the pictures, reduced range of motion, and sometimes people develop different cysts. So you can see in that picture, people have like these little nodules on the tips of their joints, and that is quite common. So one of the things that people need to think about is sometimes with your hands, it's not always arthritis. So it can also be inflammatory arthropathy, so such as rheumatoid arthritis, things like gout, septic arthritis, and also I've just mentioned tendonitis. So a lot of the times people come in and actually they either have tendonitis where their tendons and muscles are kind of sore, or alternatively, people will also talk about having kind of nerve problems. So sometimes people will come in and they think they've got arthritis. In fact, they've got carpal tunnel symptoms. So often these cases, you can have a couple of different symptoms, and sometimes we need to figure out which is the main symptom or what's really causing the problems. So how do we diagnose osteoarthritis of the hand? So generally speaking, it is mostly a clinical diagnosis. You can kind of see on the hand there the deformities that people see. You can see the bony enlargements, the nodules, and you can see on the thumb what they call kind of squaring at the base of the thumb, which is really quite an interesting thing. So a lot of the times when you look at your thumb, I'm just going to bring my hand around there, your thumb normally sits like this. Okay, so you can see there's a nice kind of a C posture. And what happens is as people get arthritic changes, the knuckle here actually starts to drop down, and you can kind of see it's already forming that kind of a posture that you can see in the picture. So as a consequence, this joint kind of subluxes out. Consequently as well, people will then get kind of web space tightening through here. So it's quite obvious when people present whether or not we kind of suspect that they have arthritic changes going on. Things that we can also do, obviously, x-rays, blood tests. So blood tests just to rule out that it's not rheumatoid arthritis. And obviously, if it is, it's fine. We can always send you to a rheumatologist to have a chat about medications and all those kinds of things. X-rays, what we're looking at, lots of joint spaces. Okay, and so again, you can see in this picture, if you look at these knuckles, you can kind of see these nice clear joint spaces where there's nothing in them. So that's the cartilage in there. Okay, so you can't see the cartilage, but you can see the bones, whereas you can kind of see as you get up to these joints, you can see how there's almost no little blank space there. So that's where you see the arthritic changes. And same thing here, right down the base of your thumb. Okay, so there, that's what we're looking at. Osteophyte, so that's kind of like extra bone growth. So you can see just through here, there's a little bit of extra bone growth. Okay, you can get some cysts, which is kind of just through here, and you can get some sclerosis. That's down through here. All right, so in terms of management of arthritis, I tend to break it down into 3 main steps. You've got your conservative management, your medical management, and then obviously your surgical management. I'm probably not going to go too much into the medical management. Just obviously, as physios, we don't really go down that path, and I would normally refer you to a GP or your rheumatologist to have a bit more of a conversation in regards to that. But yeah, we will briefly touch on that. And then again, I'll have a bit of a chat to you about surgical management. But again, not being a surgeon, I can kind of briefly give you options, but not really go into the details of that. But I will go into a lot more detail in terms of conservative management. So in terms of conservative management, what can you do for your hand? So one of the main things is education. So if the more you understand about your hand and the arthritic changes and pains that you have, the easier it is to kind of work on managing it and reducing the progression of your condition. There's often a lot of advice about joint protection. There's exercises in terms of strengthening and just range of motion exercises, so that's keeping the flexibility going. All right, as well as non-pharmacological interventions. So that means heat or ice, as well as joint support such as splints. So in regards to heat and ice, it varies from person to person as to what they like. As a general, most people like heat. I personally don't mind if you use heat or ice. What I usually suggest though is if you have an acute flare up, so again, if we're talking about that person who spent the whole day out in the garden and their hand really hurts, I would be suggesting you use ice in that instance, simply because of the fact that it's a kind of like a new injury or a new flare up of your arthritis, and you want to calm that down. Okay, but as a general, if it's just an everyday ache and pain, I kind of say a hot pack is nice, whether that is a hot water bottle, a wheat pack, a hot bath, a hot shower. I don't really mind. Nothing, there is no type of heat that's better than the other. Other things that sometimes people like to use are kind of, your deep heat creams and all of those. Again, I'm a big fan of those. It kind of helps to kind of calm everything down and just touch it down a couple of nodules so it feels just that little bit more effective. Joint supports, I'm going to talk about splints a little bit later. And then obviously physiotherapy. So one of the things that I find really difficult is, everyone always wants to know what exercises to do. And often I kind of say, it's really hard to say because everyone's different. Yes, there's a million different exercises online, and I'm happy for you to go through all of those. But what you'll find is a lot of them won't necessarily be effective for you. So mostly as physios, what we'll do is we'll assess your hand. We'll figure out the most important one. So for me, I usually only give people 2 or 3 exercises, and that's it. I would rather you do 2 or 3 exercises and for you to do them well, whether they're stretching exercises, movement exercises, or strengthening exercises. And again, it will depend that you may have a good day where your pain is not too flared up and you may do more strengthening exercises. Whereas you may find on the days where it's a little bit more sore, you might do more calming exercises, so just movement exercises to maintain your flexibility. So it's hard to say exactly what exercises. I have gone into a little bit more detail in terms of exercises for the thumb a little bit further down. And again, I'm happy to answer people's questions in regards to those as well. Does anyone have any questions at the moment? Do I need to pause here?
You can, because there are some questions. So good work,
Okay.
everyone. Questions going early tonight. And there's a couple of really good ones already.
Okay.
Just because you were talking about exercise, I think this is a really good question. I'd be really interested in how you answer this. We get asked this a little bit in clinic about all types of exercise. So Yvonne shared, exercise is recommended for basically everything now. And I hear you. It's like, oh gosh, another thing that exercise is meant to help. But wouldn't it be wiser to move the affected joints less to avoid further rubbing of reduced cartilage next to, bones that have lost a little bit of that? So, how would you answer that, Michele, in terms of helping?
Yeah, look, I agree 100%. And that's what we talked about education with arthritis, because what it comes down to is actually finding that balance between resting and using it. Okay. So what I try and explain to you is, your hand is not like a 15-year-old person's hand. Okay. You can't spend the whole day in the garden and then cook and chop a whole lot of vegetables and go do the gardening and the housekeeping all in one day and not expect your hands to be sore. So it's about finding that balance. So what we don't want you to do is to spend the whole day in the garden. What you might find is, yes, go to the garden and you might just find doing half an hour is quite good. So that's what I'm talking about in terms of resting and use. So when you have a flare up, you would probably rest your hand more. And that's where we talk about having splints to let you rest, because like you said, we want to settle down that inflammation, and that might be using ice or some medication or whatever else it does. Okay. And during that time, I would be getting you to do less exercises, but I'd be getting you to do the bare minimum to maintain your flexibility. All right. The reason for that is if you just rest the whole time, then your hands get stiff and then your muscles get weak. Okay. So then what you find is that when you do finally decide to use your hand, actually it's even more sore than if you had just maintained doing a little bit every day. So that's how I kind of explain it. I explain a little bit, but often, as opposed to going 100%, once a week type thing. Does that make sense?
I think so, but Yvonne, you're free to let us know in the chat. Because I guess with hands, and it's, I guess, similar to feet, but I think with hands in particular, it's hard to fully rest them. We've got to keep using them to eat, to cook, to just lift up our hands and things. So I guess that can make it hard in sort of juggling.
That's right. That's right. And that's why we have splints. So we have splints that are often made out of neoprene, so like wetsuit material. And sometimes we have them that made out of a hard plastic, which will really force you to rest. So again, it depends on the level of your discomfort as to how much support you will need. The other thing to think about, like you said, is in terms of the hand, is you use them so much. So it's impossible to rest. It's impossible to not use them. But what you want to think about is there's a lot of aids out there. So, you can get an electric jar opener. You can get an electric can opener. You can get, you can get a device to help you hold an ice cream cone. There is literally a device for absolutely everything that you would possibly need. And that's kind of what I encourage people to do. And what I kind of explain to people is that, you only have one set of joints. Sure, we can talk about medicine. Sure, we can talk about surgery. But if we don't want to talk about that and we don't really want to talk too much about going down that path, what I kind of say is you can choose, kind of like a car. You could drive it off-road every day, up and down mountains all over the place, but your car is not going to last very long. Yeah. Or you could choose to drive your car to the shops and to go out and visit your friends, or to go out to the golf game. Yeah. And you can choose how much you're going to kind of use that car. And and then you'll know how much wear it's going to have. So for me, I kind of say to people, you don't have to chop your vegetables. Sure, you've done it all your life, but you don't need to. You could use a blender, okay, or one of those electric chopping devices. Yeah, or you can go to the supermarket and buy them pre-cut. Sure, it's not perfect. It's possibly not how you like them cut, but it will do. And what that means is then you then preserve your hands, your joints, for the things that you want to do. And that might be sewing, that might be knitting, that might be playing cards. I don't really mind what that is. But for me, the whole purpose of life is to enjoy it, to be with your friends and to do the things that you like. And for me, that's my goal. My goal is you don't have to chop your vegetables. You can get something else to do it. You don't have to open a can. You have a machine to do it. Yeah. But then that way, your hands, you can use them for the things that you want to do. You can go out to a restaurant and hey, you don't need to wear that big, fat, hard, ugly splint that hand therapist made. But you might have to wear it when you're vacuum cleaning at home. Yeah. So it's finding that balance between resting your hand and then using it normally.
Good one. That's helpful. I see you're very passionate about this, Michele. That's why it's good.
Very.
It's good.
It's hard. Right. So much of it is education. And I think the more everyone understands, it just makes it a lot easier.
Definitely. And it's funny because, again, we get used to doing things a particular way, and it's just might not be till someone suggests that, there's other aids or other ways to get it done, then that can be, part of getting the process going. All right, I'll ask you a few more questions about other treatments before we get into this. So someone read first up, I've never heard of this, but I bet you have, but someone said bee venom treatments, are they supposed to help? Have you heard of that before?
I haven't heard of that. No. There's a lot of treatments out there. I would be speaking probably more to your medical doctors in regards to bee venom. I'm not sure. I'm assuming you're not injecting that. I'm assuming it's a cream that they're turning it into, though I am unsure.
You're not listening.
Oh, hello? Did someone? Oh, that's okay. I'll put it back on mute. Okay. But maybe feel free to give us more detail, and then we might be able to discuss it a bit later as well. But cortisone injection, I thought this would come up in questions if you're not covered it. But what do you think about that? And both maybe for osteoarthritis, but there's definitely some people tonight that have inflammatory type arthritis as well in their joints. So yeah, I guess, how do you see that fitting?
Yeah, look, I think cortisone injections have a really good place in terms of arthritis for your hand. So a lot of times when people come in, they might have a lot of painful joints. So what you really want to do is figure out which is the most painful joint. If you've tried splints and ice and exercises and that's not enough, absolutely your steroid injection will be your next point of call. Okay. And it's literally local. They mix it with a local, so it will often be numb, and it will be numb for maybe 2 hours. Something for you to be mindful of is it will often be more sore for about the first 2 days after your injection. Okay. And then it will have a really good active effect over the next 6 weeks. And all it does is that basically, if you have an injection into your joint, it just locally reduces the swelling through there. And because there's no inflammation, there's no swelling, it settles down your pain. And for some people, it does a really good job and they don't need to worry about it anymore. For some people, it comes back, and you are allowed up to 3 injections in any joint before they say no. No more joints, no more injections. You need to start talking to a surgeon. So yeah, so for me, I'm certainly a big fan of trialing a steroid injection, especially if it's getting to the point where the splints and things don't help. And it's a good place to go if you're trying to prolong or avoid surgery.
Beautiful.
From a rheumatoid arthritis point of view, if your rheumatoid arthritis is active, I don't necessarily know if a steroid injection is appropriate. I think medication is the better option to go for. And one of the reasons being is with steroid injections, it does make your tissues a bit fragile. So tendon ruptures and things like that can be a risk. So obviously with people with rheumatoid arthritis, which is more of an inflammatory and erosive condition, people's tendons will often rupture as a consequence. So I don't know many people who have had rheumatoid arthritis who have had an injection. In fact, I don't think I know anybody who has. I think it's generally medication, get your rheumatoid arthritis under control. So it's kind of just calm. It's not in its reactive phase. And then depending what's happening at that point in time, it's splinting or surgery to fix up those problems.
And just on that, Michele, how long do cortisone injections typically last, and who actually does them? Who do you refer to, or who do people need to see to actually get one?
So you can get a steroid injection either from your GP or a rheumatologist or your hand surgeon. Typically, if you get an injection done by, and I think a rheumatologist or a surgeon, the cost of that steroid thing, it doesn't get covered under Medicare, but it is a little bit cheaper if you get it ultrasound guided. So getting a referral to get that. And a lot of surgeons, especially hand surgeons now, are moving towards actually referring for an ultrasound guided one. And the reason for that is obviously they'll have an ultrasound, they can visualize the joint or the space or where the inflammation is. They can then visualize where the needle is going and making sure that it's getting to the right spot. But yeah.
Okay, I'm going to ask maybe one more. I think this is a real practical one. And I'm sure we've both been guilty of this at different times, but Gabriella shared that she's been given about 10 exercises by her physiotherapist.
Yes.
She still doesn't know how to start. And she shared she's got RA. So yeah, I guess if you got any words of advice, and I guess I'd just say, if you can, it'd be passing that feedback back on to your physiotherapist that you're feeling a bit overwhelmed and it's just a bit too much, and hopefully they adjust. But Michele, have you got any other strategies for that?
Look, I would definitely be going to your physio and giving them that feedback, because like I said, most of the times, certainly from my experience, I only give people 2 or 3 because I find after about 3, people's eyes start glazing over. And so I know that they're not taking any of this in. So I'd rather start them on 2 or 3, get it right, And then I get them to come back in 3 or 4 weeks and I'll check them. Okay. And at that point in time, the question is, do I modify them or make them harder? But then that way I can constantly kind of change those exercises. And so what you'll find is if you then get a relationship with your physio, you'll then find you'll have a set of exercises. So then, like I was talking to people about before, you know, if it's a flare up, I'll have a set of easy exercises, which are more movement exercises. And they'll have a harder set of exercises and then more your strength exercises. Okay. And they would be the ones where on a good day you might be doing those. And you might only do those harder exercises maybe 2 or 3 times a week. Okay. Whereas the movement exercises, you could almost do most days of the week.
Beautiful.
Okay. As a starting point, if you're given 10, normally the ones that they gave you first are the easier ones. So I'd just start with those. But yeah, I would probably go back, show them how you're doing your exercises, because chances are, you know, you might need to have them changed or modified if you're feeling overwhelmed. Yeah. And I find if you're feeling overwhelmed, chances are you're not going to be doing them. So yeah, like I said, I'd rather you do a couple and do them well rather than have your whole regime, but you feel lost and you don't know where to start.
Beautiful. I'll let you keep going, Michele, but just so you know there, and we will try and get back to some of these questions, but there's questions about sleeves, compression sleeves. There's questions about self-massage. There's some great questions, but anyway, I'll let you keep going. And then,
perfect. Yeah, I think I'll probably answer some of them as we go through, but yeah, definitely they sound really good. All right. So like I said, I'm not really going to talk much about medication. So like we said, we've got topical NSAIDs, we've got analgesics. These are things that you probably want to be speaking to your GP, your surgeon, your rheumatologist in regards to. But there are a lot of different medications out there. And certainly from a rheumatoid arthritis point of view, there's a lot of new medications out there that people are happy to kind of work with and play around with. Surgery. So surgery is really only considered if conservative, so that's the stuff that you and I have kind of done, and medical interventions have basically failed. All right. This is when your joint symptoms are so sore that you can't do the things in life that you want to do. Okay. So that's really where you want to think about. It's not for a little bit of aches and pains. You don't really want to go down this path. Options for surgery. You can have joint replacements. Okay, and in your hand, you can have joint replacements in your thumb joint down here. You can have joint replacements in these knuckles, these ones through here. You can even have joint replacements in these knuckles, so your PIP joints. Okay, so it's pretty amazing. And the ones for your finger, they literally look like a mini knee replacement, for one of a better description. So they're great options. You often won't necessarily have as much movement or as much strength as you possibly had before your surgery. And the rehab is often quite extensive. So we're talking 6 to 12 weeks. So you'll be in splints, you'll be in casts, you'll have a dressing. So it's not just a straightforward, I'll do surgery and I'm all good. Okay. Arthrodesis, so that is a joint fusion. So a lot of the times if people say in your tip joint, you know, when people have their tips are kind of deviating side to side, often with those tips, they will just fuse them. Okay. And so that basically means you can't bend them. What you'll then be able to do is what I'm doing here, and that's what we call a straight fist. So there. So rather than tucking the tips in, you would then do that. Okay. But you'd be able to bend everything else. And that's a really lovely procedure for someone who's got, you know, deviation and pain in those tip joints, and they just want to get rid of their pain. The last thing is a joint denervation, and that's kind of a newer thing, I'm going to say, and certainly a growing in popularity thing in Australia. I think overseas they use it a lot. And a denervation basically means is your joint or all your joints everywhere in your body, they have a nerve going into it. So what the idea behind it is if you cut or destroy that nerve, then you can't feel your joint. Okay. It doesn't mean you lose muscle movement. It doesn't mean you lose any skin loss. These are quite deep nerves that kind of just go into your joint. So a lot of times people are now for your base of thumb, which is kind of the most common area for people to get arthritis and pain. Joint denervation surgery is becoming increasingly kind of more mainstream, I'll call it. One of the downsides that people are talking about is it may not have a long-lasting effect. So it may only last 5 or 10 years. So again, it's not necessarily a bad thing. Again, with the base of the thumb, which is where most of the surgery is because it's where most people get their pain, historically, most people have done what we call a trapezotomy, and that's where they take the bone out, okay? And they basically, then there's no bone rubbing on bone. They get a bit of one of your tendons, they roll it up, and they just shove it basically back into that hole, okay? And that's been great, but you lose a lot of strength. So more recently, they have been doing joint replacements at this joint. Historically, they've had really poor long-term outcomes where people have had to have them removed and everything else. There is some newer research kind of saying these newer joint replacements are pretty good. The downside to them is they're only about 5 years old, so they've only been following up these patients for 5 years. So most people in Australia are not having these joint replacements at the moment. Most surgeons in Australia are watching the research and waiting for 10 years to come up before they start doing them. So that's kind of a bit of a wait and see kind of thing. And I guess in a way, that's where that denervation might come in, where, if your pain in your thumb is so bad, having a denervation might be a good option as a kind of just to hold you off in terms of before you think about having a joint replacement down the track.
So you've just finished watching part 1 of one of our recent educational events. Hope you enjoyed the content. If you'd like to access part 2, then you need to sign up for BJC Connect. It's a free platform where you can access not just the recordings of past events, but also access a whole range of upcoming future events and access our team of facilitators live. All of the details that you need to join BJC Connect are now flashing up on your screen. But otherwise, like our staff, subscribe if you'd like to see more information from BJC Health. Look forward to seeing you in an event soon.